Thank you, everyone. My name is Samir Oza. I am an electrophysiologist, or as you guys call me, a heart electrician at Boulder Heart. Tonight's talk will be myself, Dr. Iyengar, and Vitaly Batalini. Dr. Mahan cannot make it tonight because he is sick. So this is our team. Myself and the gentleman in blue scrubs, Dr. Sam Asnarao, are the electricians in the group. Dr. Iyengar to the far left, Dr. Mahan, our cardiothoracic surgeon, to the far right, and Vitaly in the center, as she should be. So let's jump right in. Let's talk about atrial fibrillation and what it means. It's the most common arrhythmia in the United States. When I made this slide, 2.3 million people in the US had AFib. I think now it is probably higher. A common rule of thumb is by age 65, 8 in 100 patients, or 8% of the population, will have atrial fibrillation. By age 80, 1 in 4 patients develop atrial fibrillation. So as you can see, it is one of the most common heart diseases that we take care of. And it is very important because it raises the risk of stroke by 500%. And it is good that we are talking about atrial fibrillation in September because the Heart Rhythm Society has made this Atrial Fibrillation Awareness Month. And I think if by talking about this, we can prevent 1 stroke today, it will have been worth the effort. So what is atrial fibrillation? If you talk about a normal heartbeat, it starts in the top of the heart and progresses to the bottom of the heart. And the heart beats anywhere between 60 to 120 beats a minute with mild exertion. With extreme exertion, one can have a heartbeat of 150, 180 beats a minute, depending on one's age. With atrial fibrillation, the atria, or the upper chambers of the heart, are essentially quivering. They don't beat. Visualize a bowl of jello and you tap on the bowl. That's what the upper chambers of the heart are doing. Electrical signals, if you care to count them, are somewhere in the range of 300 to 350 beats per minute. Not all of them go to the bottom chambers of the heart, but the bottom chamber beats irregularly and often fast. As I mentioned earlier, by itself, atrial fibrillation is not dangerous, majority of the times. But there are 2 specific risks. One is the risk of stroke due to blood flow stasis. Essentially, if you have a river, there's no algae that grows in the river. If you have a pool of standing water, you see algae and all kinds of bugs in there. That's essentially what happens to the blood. If the blood sits around in the heart, clots form, and they go to the brain and cause a stroke. And I'll show you some more details on that in a minute. The other risk with atrial fibrillation is the risk of weakening the heart muscle because of fast heart rate in the bottom chambers of the heart. As cardiologists, when we talk to each other, we like to classify atrial fibrillation into 3 types. Paroxysmal atrial fibrillation is atrial fibrillation that comes and goes, stops by itself in less than 7 days. Persistent atrial fibrillation usually lasts more than 7 days or requires cardioversion, which is an electrical shock to the heart to bring it back to normal. Permanent atrial fibrillation is when the patient and the doctor decide that we are going to leave the patient in atrial fibrillation. So essentially atrial fibrillation that is here to stay. There is a subcategory of persistent atrial fibrillation that is called long-standing persistent atrial fibrillation. That is atrial fibrillation that has been constant for a year or longer. So we talked about age as a risk factor for atrial fibrillation. Typically involves people above age 60. But since I have been here in Boulder over the last 15 years, we have seen atrial fibrillation in patients at younger and younger ages. The youngest patient with atrial fibrillation I have personally seen was 18 years old. And we are seeing a lot more atrial fibrillation in 30 and 40 years old. And we will talk about why that might be. Diabetes raises your risk of atrial fibrillation. Heart problems like high blood pressure by causing stretch of the upper chambers of the heart causes atrial fibrillation. Heart valve problems, especially a heart valve called the mitral valve, which sits on the left side of the heart. If it starts leaking, it causes stress on the upper chambers of the heart and makes a person prone to atrial fibrillation. Coronary artery disease, congestive heart failure, prior heart surgery, or congenital heart disease are all risk factors for atrial fibrillation. Hyperactive thyroid makes one prone to atrial fibrillation, and this is one type of atrial fibrillation that can be completely cured by a non-cardiac solution, i.e. taking care of the thyroid problem. Lung disease like COPD or emphysema, and more sleep apnea make a person prone to AFib. Alcohol use. When my patients have atrial fibrillation and it is not controlled, I tell them to quit alcohol because that is a very common trigger for atrial fibrillation. We've all heard about the holiday heart syndrome, where young kids will party, drink a lot of alcohol, and next morning they will get atrial fibrillation along with their hangover. But what we are learning more and more, that even 1 to 2 drinks an evening may make you more prone to AFib, especially if you've already had an episode of AFib. Similarly, smoking. The ERIC study showed that the risk is increased by a factor of 2. And specifically in Boulder, endurance exercise increases your risk of not only AFib, but also ventricular arrhythmias. As a matter of fact, the Heart Rhythm Society now says that endurance exercise is a risk factor for atrial fibrillation. How do you define endurance exercise? Those studies have just started coming out, but anything more than 12 hours per week might increase your risk of both atrial and ventricular arrhythmias and scars on the ventricle. So what are the symptoms? About half the patients have no symptoms of atrial fibrillation, and this is where atrial fibrillation becomes dangerous, in that patients show up with either a stroke in the emergency room, and the first time we find out they have AFib is when they have a stroke or when they have a weak heart muscle. Other patients have symptoms. They can be fatigue or lack of energy, or as some of my patients tell me, "Doc, I'm just getting old." Well, sometimes it's not old age. You might want to get checked out. Palpitations, which is irregular, fast or slow heartbeat. More commonly fast, but some patients will actually paradoxically develop a slower heartbeat with AFib. Shortness of breath, dizziness or fainting, chest discomfort, especially if the heart is beating too fast and is causing strain on the heart. So let's dive in a little bit more into stroke. Dr. Iyengar is going to talk a lot more about stroke, but 15 out of 100 strokes in the US are caused by AFib, and majority of these are preventable if early treatment is initiated. 88,000 deaths, $16 billion in additional costs to the healthcare system are caused by AFib. And as I said before, 3 out of 4 strokes can be prevented. So if you can advance the slide, this is just a cartoon that is showing how stroke happens. So you see the bottom chambers of the heart beating, and I don't know if the pointer is going to project, but at the top right hand where we are zooming in, you're seeing the blood cells forming a little clot, especially in a part of the heart called the left atrial appendage. That little clot you see is now traveling to the bottom chamber and through the aorta and carotid artery to the brain. It cuts off blood supply to the brain, and that leads to a stroke. Next slide, please. So let's talk a little bit more about AFib and cardiomyopathy. What is cardiomyopathy? Weak heart muscle. Any weak heart muscle can lead to symptoms of shortness of breath, decreased exercise tolerance, swelling of the legs, etc. And those symptoms are called congestive heart failure. How does it happen? I alluded to it a little bit earlier. Untreated AFib, especially when asymptomatic, a lot of the signals travel from the top to the bottom of the heart through an area called the AV node. The ventricles or the bottom chambers beat fast. Heart is a muscle. If you work it too long, too hard, it becomes weak and causes cardiomyopathy. Next slide, please. So how do you diagnose atrial fibrillation? It can be with an EKG. If you are in AFib, when you come to your doctor's office, that's easy to catch, but doesn't always work that way. You may be in normal rhythm when you show up at your doctor's office. Sometimes we have to put long-term monitors, a Holter monitor for 1 or 2 days, event or mobile telemetry monitors for 2 weeks, 4 weeks. Sometimes we put implantable loop recorders, which are little monitors that I'll show you here in the following slide, that goes under the skin and stays in a patient's body, just under the skin on the chest, for up to 2 or 3 years. Anybody who has AFib, we want to do an echocardiogram on that patient to look at their heart function, the strength of their heart muscle, and also the heart valves, because those can be common causes of AFib, or AFib could be causing a weak heart muscle. One can do a transthoracic echocardiogram, which is done from the outside, or a transesophageal echocardiogram done under anesthesia through the food pipe. The food pipe sits very close to the left upper chamber of the heart where those clots form. And so before we cardiovert or shock a patient back into normal rhythm, we will do a transesophageal echocardiogram in majority of the patients. Next slide, please. This is the monitor that I was talking about. It is 3 or 4 companies make this. This particular one is made by Medtronic. It's about the size of a large paper clip, and it goes under the skin. Next slide. So how do you treat atrial fibrillation? The classic 3 pillars of treatment are to prevent stroke, control the heart rate, and bring a patient to normal rhythm. We started talking about a 4th pillar of atrial fibrillation management, which is risk factor modification. But I really think it should be the first pillar done simultaneously with the first 3 things. So let's talk about it a little bit. Preventing stroke is done with blood thinners. We'll talk about it in the next slide. Go ahead. Next slide. How do you do that? Warfarin is a common blood thinner. Coumadin has been around for 30 or 40 years. It has mostly been replaced by what we call the DOACs now, the direct anticoagulants. You see a lot of ads about this, Pradaxa, Xarelto, Eliquis. Those drugs truly work better than warfarin. They are more convenient. You take them once for Xarelto and twice a day for Eliquis and Pradaxa. And in patients who cannot tolerate these blood thinners because of bleeds or frequent falls, we target the left atrial appendage, which is where 90% of the clots form with AFib. And that can be right up Dr. Iyengar's alley, or if with a Watchman procedure, or if the Watchman procedure is not suitable for the patient, our surgeons can go in between the ribs and take out that part of the heart, the left atrial appendage, and just clip it with a special stapler called an AtriCure device. Next slide. Rate control, the second pillar of atrial fibrillation management. It's achieved with two drugs, most commonly beta blockers. There's a variety of them available: metoprolol, atenolol, propranolol, or calcium channel blockers like diltiazem, verapamil. We used to use a drug called digoxin. We don't use that much anymore. And in some patients who cannot tolerate these drugs because of low blood pressure and are not candidates for the more detailed ablation that I'm going to talk about later, we sometimes do a procedure called a pacemaker and AV node ablation. Next slide, please. So, as I said, these are patients who are in atrial fibrillation all the time, permanent atrial fibrillation, or have very severe symptoms with their paroxysmal atrial fibrillation. We first place a pacemaker either under their collarbone with two wires going to the heart, which is a traditional pacemaker, or what is called a micra pacemaker, which is a leadless pacemaker implanted directly inside the right ventricle. We let that heal, and in a few weeks after that, we do AV node ablation. As I mentioned before, this treatment is reserved for our older, frail patients who cannot tolerate AFib ablation. Next slide. So here's the, go back one slide. Here's the two pacemakers that I was talking about. On the left, the bigger device is called a dual chamber pacemaker, meaning pacemaker with, this particular one actually is a single chamber pacemaker. A dual chamber pacemaker would have two wires, one in the top, one in the bottom. And on the right lower corner, the little device is about the size of a prenatal vitamin, and that's implanted directly into the right ventricle or the right bottom chamber of the heart. There is no scar on the chest like a traditional pacemaker. We go in through the legs, straight up into the heart, deploy this device, and they usually last 8 to 10 years. Next slide, please. Once the pacemaker is in, we do a AV node ablation. So if you look at the left side of the screen, the big spikes are the heartbeats, and as you can see, they are fast and irregular. If you look at the bottom of the screen is where we turn the energy on, that's represented by the green graph. And as we move forward in time, you see where it's labeled block and paste. The AV node, or the connection between the top and the bottom of the heart, stops conducting electricity, and the pacemaker automatically takes over the heartbeat. The downside to this is the patient is pacemaker dependent. The upside is that pacemakers are extremely reliable, and we can now control the heartbeat without any medications on board. Next slide, please. The third pillar is rhythm control. So if a patient comes to me initially and they are seen to be in AFib, the first thing we are going to do is we are going to put them on one of the blood thinners, and we are going to do a DC cardioversion. What does that mean? Patient is given anesthetic, and then a shock is delivered which converts the heart rhythm to normal. It is essentially like pressing Control-Alt-Delete on your computer. It resets the heartbeat and brings the heart back to normal rhythm. Downside is it does not do anything to keep the rhythm normal. So the statistics, as you can see, it is effective almost 100% of the time, but within a year, about 7 out of 10 patients, or 70%, are going to be back in atrial fibrillation. We can improve our chances somewhat, about 40% or so at 1 year, or maybe 50% with this drug called amiodarone, by using a wide variety of antiarrhythmic drugs. I've listed the 6 most commonly used drugs. And as you can see, when there's 6 of something for one problem, it tells you none of them is perfect. Each of them has a side effect, and each of them has a limited success rate. And in some patients, the drugs may work initially. After a year or 2 or 5, the drugs stop working, and we either have to increase the dose or try a different class. So while they are a good first treatment in a good number of patients, they are not perfect. Next slide. So that's where ablation comes in, and it is probably the best treatment we can offer you outside of a surgical procedure. Since Dr. Mahan is not here, I'm going to talk about 2 surgical procedures first and then talk about the rhythm control approach. So the best treatment for atrial fibrillation is an open heart maze procedure. So that involves a sternotomy, putting the heart on heart-lung bypass, and the surgeon does a variety of techniques to do what is called the Cox Maze 4 procedure. And the long-term success rate of that procedure is more than 95%. The second thing that Dr. Mahan was going to talk about today, and we do that in combination. So it is Dr. Mahan doing the surgery and then me doing an ablation. That combination is called a hybrid ablation procedure. And the way that is done is it's done on a beating heart. It does not require a sternotomy, and the surgeon makes incisions both from the right side of the chest and the left side of the chest and isolates the pulmonary veins. I'll show you some pictures along with my pictures of what the surgeon does. We let the patient heal after the surgery. One other thing, in addition to the surgical lesions that Dr. Mahan places, he takes out the left atrial appendage, so that reduces the future risk of stroke. That is followed by a catheter-based ablation at 6 weeks to 3 months to touch up the areas that may have regrown after the surgery, or some areas that the surgeons cannot get to from the outside. Both those procedures together are called the hybrid ablation procedure, and we are one of the few centers in Colorado that offer this procedure. The success rates for that are somewhere in between the full surgical maze procedure and the catheter-based ablation that I'm about to describe. So let's jump into catheter ablation procedure. Go back. The effectiveness for catheter-based ablation is based on the type of AFib. So I don't know if you remember, at the beginning I said there are 3 types of AFib for classification. And the second type has 2 subtypes. So paroxysmal atrial fibrillation is the arrhythmia for which ablation works, the catheter-based ablation works the best. And just last week there was a study that showed that earlier we get to patients with paroxysmal atrial fibrillation, the slower their future progression of atrial fibrillation is. Success rate is about 70% with a single procedure for paroxysmal, and in about 10 or 20% of patients we have to do a second ablation procedure, which raises the success rate to about 85%. For persistent atrial fibrillation, a patient who has been in AFib for less than 1 year. The other type is called long-standing persistent AFib. I personally do not do ablations for long-standing persistent AFib because I think they are better served by the hybrid ablation procedure that I just talked about. But the persistent atrial fibrillation patients, they have about a 50 to 60% ablation success rate with a catheter-based ablation procedure. So 2 types of ablation based on the source of energy used. One is called radio frequency ablation, which I will talk about first, and the second is called cryoablation procedure, which is freezing. There are other energy sources being developed. They are not widely available, and a lot of them are in clinical trials. So we will focus on radiofrequency and cryo. Radiofrequency ablation procedure, we essentially have a patient under anesthesia and place catheters, which are these narrow flexible tubes or plastic with electrodes at the end, which are made out of platinum. So we can record electrical signals from the heart. They are inserted through the groin. We watch them go up into the heart under X-ray or fluoroscopy. And once we reach the heart, we make a variety of measurements. Next slide. If you are on the internet, you'll hear a lot of these terms thrown around, and that's why I'm going to mention them to you. Mapping, EP study, ablation, they are all part of the same procedure. Electrophysiology study is the umbrella term, where we place catheters and do measurements and stimulate the heart. Mapping is trying to figure out the source of the arrhythmia, and the actual ablation. They're all part of one procedure. Mapping is done before ablation. We can do either conventional mapping, or nowadays we do 3D mapping in pretty much every patient. Next slide. Conventional mapping is basically using the catheters and recording electrical activity from the heart. So this is what it looks like. This is what I stare at all day long in the EP lab. The top 3 lines are the EKGs that are recorded from the surface of the body, and the subsequent squiggles are electrical signals from inside the heart. Next slide. 3D mapping is basically like a GPS system. We have magnets behind the patient's back. The catheter has sensors for those magnets. And in addition, we have electrical fields, very weak electrical fields that the catheter detects. And using those 2 technologies, it gives us a location in space, and at the same time, we record timing. We use for AFib ablation, CT scans, or sometimes MRIs, and bring that data, next slide, and bring that data together along with our map to create one image. And I usually use these images to be working on a patient. So what you're seeing here is a typical radiofrequency ablation patient. You're looking at the heart from the back. You're looking at the left upper chamber of the heart. The tube that is going by there is the esophagus, which lives very close to the left atrium. And the 4 branches you are seeing are the pulmonary veins that bring blood back from the lungs into the heart. And most of the triggers of atrial fibrillation, especially with paroxysmal atrial fibrillation, live in or around the veins. The red dots that you are seeing are places where I have placed an ablation lesion, and essentially what we are achieving with an ablation is electrically separating the veins from the left atrium. So the electrical signals from the veins do not go into the left atrium. And if atrial fibrillation is starting in or around the veins, the rest of the heart does not follow. So that's the primary purpose of radiofrequency or cryoablation. Next slide, please. This is just a different view of the same. We can slice and dice the atrium to get endoscopic views. We are looking at one of the veins and how I place lesions, being careful not to go inside the vein. Next slide, please. So you saw in radiofrequency ablation where we have to go point by point, kind of do a spot welding around each pulmonary vein. We can achieve the same thing faster, and at least in my own experience, a lot more efficiently and safely with cryoballoon ablation. So next slide, please. This video is going to show you the cryoballoon ablation. We are placing a catheter inside the left atrium, and this is a mapping catheter that's being placed inside the vein. The balloon goes over that catheter and is placed against the vein. And you're seeing a cross section here. The front half of the balloon freezes and creates a circumferential lesion around the pulmonary vein, essentially isolating the vein. Usually we get isolation in anywhere between 30 to 60 seconds, and we do a 3-minute freeze for each vein. Sometimes we have to do more than one. Next slide, please. Since Dr. Mahan is not here and we have a little bit more time, I would like to talk about risk factor modification. All the things that we have talked about do not work well if the patient is not doing their part. So every patient who comes to my clinic we will talk with them about aggressively modifying their lifestyle. There are studies from Kansas, there are studies from Australia that have looked at lifestyle modification and the fact that ablation doesn't work as well if the patient doesn't do their part. So the few things that Vitali talks with every patient in clinic before I ever see them is cutting back or eliminating alcohol, getting good sleep 8 hours a night, moderate exercise 1 hour a day. So people who are not exercising are encouraged to exercise. Some of my over-exercisers in Boulder are asked to cut back maybe. Sleep apnea is looked for and treated in every patient. We check blood work to look for thyroid anomalies or any electrolyte abnormalities. And we talk about this every time, and I will tell you, most of my patients who do well or are my star patients with ablation are the patients who had an ablation procedure along with the lifestyle change. I've had a few patients who have chosen not to take medications or ablation, and we do insist that they take blood thinners if necessary, but they have all achieved better control of their atrial fibrillation with lifestyle. So with that, I will leave you and we will go to Dr. Iyengar. Slides are not advancing.
Hi folks, thanks for tuning in tonight, and thanks for Dr. Oza for giving the introduction about the background of atrial fibrillation. My name is Dr. Srini Iyengar. I'm currently the Director of Structural Heart at Boulder Community Health. And Dr. Oza introduced himself as basically the heart electrician. I'm the heart plumber. So I am the one who goes and puts tubes and catheters and stents into the arteries and veins. But today we're going to talk about a little bit different type of topic, but rather stroke prevention in patients with atrial fibrillation who cannot tolerate blood thinning medication. And it looks like we'll just go forward with one slide, please. So we know AFib causes palpitations and it can cause shortness of breath, chest discomfort, but what else does it cause? Stroke. The left atrial appendage, which is in the left atrium, can collect blood, which forms clots that can break free in patients with AF. So that's why you see all those commercials on TV of the individual playing with their grandson or granddaughter, and they end up having a stroke, going to the ER, and then told you have AFib. So this is the connection. Atrial fibrillation is an irregular heart rate or heartbeat, which then causes blood to coagulate in certain parts of the heart, which then result in a clot that can break free and cause a stroke. So next slide, please. So AFib is a growing problem associated with a greater morbidity and mortality. We've discussed this in the prior discussion, but just to bring it home, it has a 5 times greater risk of stroke with atrial fibrillation versus patients who don't have AF. So 15 to 20% of all strokes are AF related, and I think it's actually higher than that. And AF results in greater disability compared to non-AF related strokes. Next slide. Their strokes are debilitating. There's no such thing as a good stroke. So number one, put that in perspective. But strokes are extremely disabling no matter what their etiology. And AF-related strokes result in 2 times the higher mortality, and 70% of strokes from AFib result in death or permanent disability. Next slide. In 2014, there was a guidelines that came out discussing how do we prevent strokes in patients with atrial fibrillation. Now, these is a little bit older guidelines, and I think it will be updated soon. But we use something called a CHADS-VASc score, as you can see there in the bottom of the slide. What that is is actually the C stands for congestive heart failure, the H for hypertension, the A for age of 75 or greater, which is given 2 points, D is for diabetes, S is for prior stroke, which is 2 points, V is for vascular disease, which includes aortic calcification or atheroma, carotid disease, or prior heart attack. A is for age of 65, which is 1 point, and S is for gender, female, which is 1 point. I know that's a lot to remember. I'm going to ask you all at the end of this. I'm just kidding. I'm not going to do that. But I will tell you that this is a score that we all as physicians remember. So when every time a patient comes into the office with atrial fibrillation, we calculate this to estimate their stroke risk. And as you can see on the right there, the recommendation, if you're 0, the recommendation is no anticoagulant. If your score is 1, it recommends aspirin or warfarin. Now, I'm going to tell you, the European guidelines have shifted to saying anybody with a score of 1 or greater should be on a blood thinner like warfarin or Coumadin or one of the DOACs. And if you're 2 or greater, naturally, we'd like you to be on a blood thinner. Next slide. But let's be honest, what are the downsides of being on a blood thinner? As you can see here, there are real risks. Blood thinners are not benign medications in themselves. The fact is they can cause bleeding issues, especially if you're predisposed to a bleed or have a traumatic issue like a head injury, or if you're fallen down and you've broken a hip or a knee. You can result in having a real large bleed because you're on a blood thinner. These medications don't make you bleed. They prevent you from clotting off and prevent you from really thickening your blood, which we like normally. But in cases of AFib, obviously, we want to prevent you from having that clot to develop. Hence, these medications prevent that from happening. So the side effects of it, obviously, are related to bleeding risks. Next slide. Next slide. Next slide. So at this point, we actually look at our CHAS-VAS stroke risk, and we estimate with your condition, and again, with the numbers that are ascribed to these conditions, and then we go to your yearly stroke risk. And as you can see on the right side of the screen, when you're on the medication versus no medication, clearly not being on a blood thinner, your stroke risk goes up exponentially as your risk factors go up from 1 to 5. You can see there's a jump from 1.3 to 6.7 with patients who do not take warfarin or a blood thinning equivalent. Next slide. So we've also come up with a score called the HAS-BLED score, which is basically another score to determine how your bleeding risk is associated with being on warfarin. Because again, not every patient is going to be suitable for being on a blood thinner. Now, there's some conditions, like if you have a history of labile INRs, or the way you check your Coumadin levels, if you have a history of bleeding, history of stroke that's from a bleeding or hemorrhagic stroke, a bleeding stroke, or you're elderly, these are all real risk factors we have to take into account prior to putting you on this medication, or at least having you informed about being on this medication. Next slide. So when we look at someone with an elevated HAS-BLED score, which again is your risk of bleeding, you can see there on the right, your annual bleeding risk goes from 0.9 when you're 0 to 9.1% risk per year, being a score of 5. So that is really, really large. And if you look into the right of that, you can see the 10-year bleeding risk percentage, 61.5 if your bleeding score is a 5. So again, when you have risk factors to bleed, but you have a fib and you need to be on a blood thinner, it's a rock and a hard place situation. So with that, we obviously have decided in medicine, what can we do about it? Next slide. Next slide. So again, we're going back to the stroke treatment options with warfarin. If you look at the right there, the arrow, there is a narrow therapeutic range for Coumadin. And a lot of patients, I would say thousands of patients, are on Coumadin and can keep their therapeutic range between 2 and 3, especially for patients with AFib. The problem is nearly 50% of those patients fall below 2 at certain times during their treatment, and 44% fall above 3 during their treatment. Neither is a good place to be. If you're less than 2, even a partial amount of the time, you are unprotected. That anticoagulant effect to prevent stroke from AFib is not there. So I have patients that come to the office all the time that say, well, I was 1.8 last week or 1.9. That should be fine, right? It's not correct. You really do need to be between 2 and 3. But the opposite is also true. You don't want to be, well, I was 3.5 last week and 3.7. That's okay, right? It is not okay, because any number over 3 that you start going over, the risks of bleeding exponentially increases. Next slide. So again, use of oral anticoagulation is standard of care, but it is very difficult for patients to stay compliant. And why is that? Well, with Coumadin or warfarin, it's about the dosing. A lot of times patients will drink a glass of wine, eat some green salad, do something where the levels will be altered by their diet. Additionally, patients don't like checking their blood levels routinely because, again, the levels could be off and we need to keep a close monitoring of it. So it is problematic. Next slide. But again, there are newer drugs that you've seen on the commercials called Eliquis, Pradaxa, Xarelto. These medications say you don't need to check your levels. You could eat or drink what you want. It's freedom from all of the testing. But let me tell you something. Those medications aren't free. And being the expense they are, a number of times insurance companies won't necessarily cover completely all 3 medications or even one of them. And again, these are medications that are preventing clotting. So even though you're not checking your levels and you could eat or drink what you want, you still have the risk of bleeding if something should happen, like a fall or something of that nature. So compliance with these medications is equally as bad. As you can see here on the slide, 30% of NOAC or DOAC patients stop taking any drugs at 2 years. Next slide. So the drugs that I mentioned, the rivaroxaban, the apixaban, and dabigatran, are all medications that are associated with Xarelto, Eliquis, and Pradaxa, respectively, and edoxaban as well. Basically, these medications have the equal amount of discontinuation rates, as you can see, almost like warfarin. And again, the major bleeding rates on the right are actually almost equivalent as well. So when you see these types of data, you know that, again, there's not one silver bullet here that can cure the clot risk from AFib via medication. Next slide. So again, let me just summarize that AF is a growing problem associated with greater morbidity and mortality with a 5 times increased risk of stroke. 90%, if not 95% of all clots in the LA come from the left atrial appendage. Current treatments with warfarin or NOACs or the DOACs are effective, but many patients stop taking these medications, and 1 in 4 patients discontinue blood thinners after 2 years. Anticoagulation bleeding risk compounds over time and may not be a viable strategy as a long-term solution for some patients. Next slide. So again, why is AFib and stroke related? Because of what we're seeing there on the right side of the screen. You're seeing that little ball that's in the middle of the screen. That is a ball of clot. And over 90% of strokes in patients with atrial fibrillation come from strokes originating in the left atrial appendage. Next slide. And I'm going to play you now, next slide please. We're going to play the video of what the path between the rock and the hard place is at this point. This is the Watchman device, which was developed because of patients who cannot take blood thinners because of falls or bleeding risks, but also had an elevated CHA2DS2-VASc score and needed to be on a blood thinner to prevent a possible stroke. This device, again, has been thoroughly researched over the last 10, 15 years and has had thousands of patients internationally and domestically enrolled. You can see here in one of the trials that 92% of the patients were able to stop taking warfarin after 45 days, and 99% were able to stop at 1 year. So how does it work? As you can see in this is a demonstration of a beating heart. And here, this slide is going to show you what the left atrial appendage looks like. And that little red ball is actually a ball of clot that's sitting in the appendage. So what happens is during these procedures, what we do is we place the patient under general anesthesia in a hybrid catheterization lab. Typical procedure time is 1 hour and 1 night in the hospital. Just for note, I did a procedure this morning that took 25 minutes. So that just shows you we can do these procedures quite quickly. This is an implant procedure with the catheter going through the vein and going up through the inferior vena cava, which is a large vein in the body. And now we bend the catheter and actually make something called a transeptal puncture. This is painless. The patient, you will not feel this. We place a wire into this atria, which is the left atria, and now we maneuver our catheter and something called a pigtail into the appendage. We then place a device into the appendage, and like a cork on a bottle, we've sealed off the appendage. And over time, the heart will grow over the device, sealing it in. Next slide. So with the Watchman device that I just showed you there, the studies have been overwhelmingly positive in reducing hemorrhagic stroke or overall stroke with this device. Now, again, we had mentioned that Coumadin or warfarin protects the entire body against any clotting. The Watchman device is specific as it protects the left atrial appendage or covers the left atrial appendage and covers from stroke from that particular area. Are there other areas of the body that could produce clot? Of course. But as we just described, the vast majority of strokes in patients with atrial fibrillation, over 95%, come from this particular area of the body. Hence, this is not an equivalent therapy for Coumadin, but rather for patients who have trouble taking long-term anticoagulation therapy. Next slide. And as we're seeing here, at 6 months, 72% of the patients who received a Watchman therapy have a reduction significantly of major bleeds. Next slide. The patient populations, who are we looking for to get this device? I'm not looking for the patients that come in and say, I hate Coumadin, or I don't want to take the DOACs. Those are not the appropriate patients who receive this therapy. This therapy is reserved for patients who cannot tolerate long-term blood thinning medication, whether it be secondary to multiple falls, recurrent bleeds, active lifestyle, like you are actively landscaping or actually working with your arms and hands in the fields where you've seen multiple bleeding episodes due to that. I often joke around that somewhat morbidly, but that when patients come to me and say they are skydivers and can't take blood thinners, I often say putting a Watchman in it is not going to protect you if your parachute doesn't open. So that is definitely not one of the indications. But I will tell you, there are a number of reasons that Watchman may be applicable to your situation, and that's why talking to your physician is the first step. So again, realistically, you want to speak to your doctor and obviously speak to a Watchman implanter if you are deemed to be a suitable candidate to discuss the risks and the possible complications of performing this device. Again, if you're tolerant to taking these blood thinning medications, I would say stay on it, because if you can avoid a procedure, then do so. But if there's any reason why you cannot take the blood thinning medication and you have that elevated CHA2DS2-VASc score, then I think the Watchman is definitely part of the discussion about your therapy moving forward. Next slide. So what if you need an ablation and ligation? Well, basically, Dr. Oza touched on this. Dr. Mahan, our partner, our surgical partner, can perform alternate therapies. Surgical procedures can be performed which can address both these issues. And if you're a patient that is a candidate for a Watchman, but unfortunately your anatomy is not suitable for the device because it's too big or too large, Dr. Mahan, our surgical partner, can perform something called an atrial clip procedure, which is surgical but minimally invasive, which he can actually clip off the appendage if obviously you're not a candidate for this less invasive procedure like the Watchman. Next slide. And at this point, I'd like to hand it over to Vitaly.
Thank you. I'm Vitaly. I'm a nurse practitioner with our A Fib Clinic at Boulder Heart, and I'm sorry that Dr. Mahan couldn't be here with us to do the next part of the talk, but I will jump right into chatting about our A Fib Clinic. So at Boulder Heart, our number one priority is patient outcomes, and when we're dealing with A Fib, that looks like best quality of life and the fewest number of symptom days possible that we can achieve. And so with this in mind, we sought to develop our A Fib Clinic to address some of the challenges that we see in our current healthcare system that can sometimes result in fragmented care and in delays in care and in patients not having the ability to access the resources and the types of information that they need to achieve those best outcomes. So we modeled our A Fib Clinic after guidelines that were proposed by the American College of Cardiology and the Heart Rhythm Society. This model has been really demonstrated to improve these patient outcomes by making sure that patients receive the highest level of care while attending to their multiple comorbid conditions, the risk factors that Dr. Oza mentioned, and receive and are connected to the types of treatments that are innovative and that can help address their symptoms, like ablation, the Watchman device, surgical intervention, so that they really can live their best quality of life. So what we did is we pulled together a number of resources to connect patients to the robust set of AFib resources at Boulder Community, and the way that we modeled that is our AFib clinic. So patients are connected with me or one of my counterparts initially, and we spend a lot of time evaluating you from head to toe, talking about some of the lifestyle considerations that Dr. Oza mentioned, talking about your overall health. We know more and more, and research has shown that AFib is often a symptom of something else going on either in the body or in your environment, a stressor that can trigger AFib. So if we just focus on treating the rhythm itself, we're missing an opportunity to achieve those fewest number of symptom days possible. We're missing a big part of the picture there. So our AFib clinic is really geared towards that whole person approach that we think our community deserves. And we focus on a multidisciplinary approach. So we pull together a number of our specialists, our neurologists, our surgeons, our pulmonologists, our folks in the emergency department, our hospital medicine team, our primary care providers, and we spend a lot of time both collaborating about our complex patients, connecting those patients to the right resources, some of which we've heard about tonight, and also making sure that all of the providers in our system have an education surrounding the most up-to-date guidelines for managing AFib, making sure that folks know how to connect patients to the AFib clinic in a really timely manner, and making sure that we reduce potential complications associated with AFib, such as stroke. So that full spectrum of care is available at Boulder Community, and we needed a way to tie all of that together. And we did that by developing our AFib clinic. So our ultimate goals came down to the fewer number of ER visits for patients as we can achieve, aggressive risk prevention, streamlined access to care that I mentioned. We really strive to see our AFib patients with a new diagnosis in a really timely manner so that they can get the information they need as soon as possible, and so that we can minimize some of those other risks that we've talked about tonight. Ultimately, this model also results in a lower cost of care for patients and their families because it's more efficient, it's streamlined, and it connects patients where they need to be when they need to be there. So the number one goal of this clinic is supportive care. It's a one-stop shop to be able to find the resources that you need to take care of yourself and have the best quality of life and the best outcomes living with AFib. These are some of the specialties that we work with closely in our AFib clinic and that we tie together through regular meetings, ongoing connections, and the facilitation of our multidisciplinary care here. So we're really excited about this program. It allows us to serve our community in the best way possible. The number is super easy to remember, 303-443-AFib. Our email is afib@bch.org, and we're available to answer questions about how best to take the next steps in your care or your family's care moving forward with AFib.
Great, thank you guys. You ready to take some questions? Okay, good. All right. So, first question, I had actually touched on this before, but if a Watchman device is used to control AFib, is it still necessary to use blood thinners?
Right, so the question is, if the Watchman device is used to control AFib, should I be on blood thinners? So the important point here is the Watchman device is not used to control AFib. Actually, it's independent of the rhythm. The Watchman device is utilized for basically strictly blood thinning elimination rather than AFib rhythm control. So the AFib will still be present or may still be present in the sense that it has no relation to the Watchman device being placed or not being placed. The Watchman device is strictly being placed to realistically get a patient off blood thinners and prevent the stroke risk associated with AFib. So again, the rhythm of AFib, the treatment of symptoms from AFib are independent of the treatment of the stroke risk from AFib, which is what the Watchman does.
Great, thank you. Vitaly, this question is for you. How long has the AFib clinic existed?
That's a great question. So we started developing the AFib clinic about 2 years ago. We officially launched, I believe it was in January of this year. And it has been a huge success. The number of folks that we have been able to connect with and therefore connect with the right resources within our facility has been awesome, and we're really proud. We're excited about this program here.
Okay, next question. Can a patient who has had a cryoballoon ablation and a radiofrequency ablation have a third ablation if paramyxil returns?
So the answer is yes. Sometimes patients do need multiple ablation procedures. I reserve those ablation procedures, especially the third or fourth procedure, for patients who are highly symptomatic, or by looking at their monitors, I can identify a suitable target for ablation. I do not believe in keeping on doing ablations like is becoming more prevalent. I think if by 2 or 3 ablations the patient does not get the result that we want, and it is a small number of patients, I refer them for a hybrid ablation procedure. Usually we have that discussion in our clinic after the second ablation procedure, the small group that is not responding to therapy, we have them see our surgeon.
Great. Is atrial fibrillation a genetic condition?
Is atrial fibrillation a genetic condition? The answer is maybe. I like to say that diets run in families, lifestyles run in families, and that's why sometimes it feels like, oh, my mom had AFib, I have AFib. There are certain genes and certain rare, extremely rare disease processes that have been identified that may make one prone to AFib. But by and large, the reason it seems to run in families is because lifestyles are similar.
How many lifetime episodes of AFib can one sustain before considering ablation?
I will take that one as well. How many lifetime episodes? It is dependent on an individual patient. I've had patients who who are explorers in Africa and remote areas. They had 2 episodes of AFib, and they wanted an ablation, and it was appropriate for that patient. I would not necessarily say it's the correct thing for every patient. Some patients may have extremely frequent episodes, several times a week, before they feel like it is impacting their lifestyle. I want to be very clear that AFib ablation is for symptom management. It's when either the patient chooses not to take some of the medications, or the medications that we have tried have failed, and it is affecting your quality of life. We do not do ablation to make you live longer or reduce your risk of stroke. So hopefully that answers your question.
Thank you. When you say AFib that lasts for a year or so, do you mean a constant, rapid, or irregular rhythm, or just regular episodes?
So the question can be answered in 2 parts. A person may have AFib for 1 year, and it may come and go, and that is called paroxysmal AFib, even though it's been going on for a year or maybe even 10 years. When I say long-standing persistent AFib, that patient has been in continuous atrial fibrillation for the last year.
What is the difference between AFib and atrial flutter?
I will answer that one as well. Atrial fibrillation usually is a irregular, or almost always is an irregular heartbeat coming from the left side of the heart. Sometimes it can originate in the veins in the right side of the heart. Atrial flutter is always a fast and regular heartbeat that arises on the right side of the heart. I do not have a heart model here, but if you can visualize the vein that comes from the bottom of the heart and the tricuspid valve that sits between the right top and bottom, atrial flutter is a circuit around the tricuspid valve. The signal travels like a car around a racetrack around 300 times a minute. but the rhythm is always regular with atrial fibrillation. Now, with atrial flutter and fibrillation, we are talking about the top of the heart. How the bottom responds, atrial flutter may also feel irregular. The other difference is atrial flutter has even more success rate with ablation than atrial fibrillation does. So we can cure 95% of patients with atrial flutter with a single procedure.
Great, thank you. Can INR testing be self-administered?
Vitaly, do you want to take that?
Sure. Yes, so there are options for home monitoring to keep track of your INR, but we tend to encourage folks to seek monitoring with our ACT clinic at Boulder Heart or with their primary care providers, et cetera, because we can offer just a bit tighter monitoring and recommendations for that monitoring. But that is an option. There have at times been certain monitors or test kits that have been recalled, and when that occurred, that's when we mostly transitioned to encouraging folks to come into clinic and let our team take charge of that monitoring and recommendations for dosing.
Okay, thank you. What causes palpitations after eating?
So, number of things can cause palpitations after eating. The food pipe, as you saw in that one picture from ablation, sits right behind the left atrium. And the food pipe or esophagus and the heart share a common nervous system, the autonomic nervous system. The vagus nerve is a part of it. So some patients actually have a swallow-induced atrial fibrillation. I actually have a physician who sees me as a patient, and every time he drinks cold water, as he claims, but I think it's cold beer, he goes into atrial fibrillation. And those are triggers from usually the right pulmonary veins that do that. Sometimes those kind of activities can also cause PACs, or premature atrial beats. So palpitations is a generic term. It's what the patient feels, and it can be caused by a number of different arrhythmias induced by swallowing.
Does atrial fibrillation hurt?
Does atrial fibrillation hurt, was the question? The answer is some patients it can. Atrial fibrillation, especially with fast heart rates, in a patient who has, let's say, coronary disease, can cause decreased blood flow to the heart, and it can cause chest pain. We've actually diagnosed patients, and this is where Dr. Iyengar and I work very closely. Anytime they need a plumber, they go to Dr. Iyengar or one of my other interventional colleagues to figure out what might be wrong with their coronary arteries. Why is this patient having chest pain with AFib?
Okay, thank you. What effect does COVID-19 have on AFib? And do we know yet?
So COVID-19, we have just started learning about its relationship with coronary disease, with clotting, as some of you have seen on the news, with cardiomyopathy, a weak heart muscle. And essentially, any systemic inflammation can cause AFib. So we have patients in the hospital who will have not COVID-19, but a different viral pneumonia, let's say, and they have AFib, and they never had AFib before. They may never have AFib again. So any systemic syndrome like COVID-19 increases your risk of atrial fibrillation.
Does ablation work if you've had AFib for 10 years or more?
So that is a long-standing persistent AFib. I hope the question is a patient who has been constantly in AFib for 10 years. If the AFib comes and goes, and sometimes patients can't tell. So if a patient comes to me and says, I've been in AFib for 10 years, the first thing I'm going to do is I'm going to put a 2-week monitor on them, and we are often surprised that a patient who thinks they've been constantly in AFib, they have periods of normal rhythm. So they are often paroxysmal AFib patients, and for them, ablation is going to work. For someone who has been stuck in AFib for 10 years constantly, and the only way we know that is they have had frequent periodic monitoring, or maybe a pacemaker, which gives us constant information about the heart's rhythm. If they've been in AFib constantly for 10 years, I do not think a catheter-based ablation is appropriate. Those patients should be considered for a hybrid ablation procedure. We have worked on some of those patients, and essentially what a hybrid ablation procedure does is it tries to create a lesion set that is very similar to the Cox-Maze 4 procedure, which is the gold standard. Some of these patients with that duration of AFib may also have leaky mitral valve, for example. And if that leakage is severe, we may ask the surgeon to fix the valve along with doing the heart surgery for AFib and get much better outcomes than just catheter-based ablation. So the short answer is long-standing persistent for 10 years, catheter-based ablation is not appropriate.
Thank you. Dr. Iyengar, do you recommend Watchman versus blood thinners for someone who is simply wanting to continue cycling, thus always having a continuous risk of a fall?
To be honest, the question is really, is cycling a major risk factor to come up with blood thinners? Now, this is something that I think has to be individualized because, I've had mountain bikers come in who've had major trauma from their events, what they're doing, and have basically told me they're not going to take blood thinner medications secondary to that. But again, if it's a hobby and it requires you to say, hey, I'm not going to do this because of my hobby, I would argue that you should stay on your blood thinner and curtail what you do on your side. Now, if you are someone who is professional at doing these types of events, if you're a professional cycling and professional mountain biker, naturally you're going to put yourself in harm's way more often. And those are patients that our discussion is really needed because, again, the risks, rewards of doing a procedure versus staying on the blood thinner need to be taken into account. Again, the risks of doing a procedure should always be less than the rewards that you're getting. So you should not go into a procedure saying, well, it's equivalent to me taking the medication. If anything, we want to make sure that if we do a procedure, the risk was worth it. So if you are in a lifestyle or something that is going to put you in harm's way on a day-to-day basis and being on a blood thinner is potentially making it worse, that is a discussion to have. Now, if you're a cyclist on the weekend or your hobby is just doing occasional cycling, I would argue that you should stay on your blood thinner because, again, that is where we have to take into account the risk of doing a procedure versus the risk of staying on that medication.
A couple of medication questions. Can high-dose aspirin therapy replace other blood thinners in minor cases?
I'll take that question. And I'll tell you, the question is, does high-dose aspirin replace any of the blood thinners? The answer is no. There is no evidence that aspirin at 81 or 325 is as effective as warfarin, Coumadin, or the DOACs, the medications we had described. So again, a lot of patients like to say, well, I don't want to be on that crazy rat poison blood thinner warfarin. I would rather just take a higher dose aspirin. Again, aspirin is not equivalent to these blood thinners and actually can have more side effects in other ways, causing potential gastric ulceration or kidney dysfunction if you take too much of it. So again, taking higher doses of aspirin is not the answer if you don't want to be on another blood thinner.
Is there a medicine that folks could keep at home to take immediately in case of stroke, like people carrying nitroglycerin for cardiac arrest? Is there anything for
medications
stroke?
You can take for chest pain, like nitroglycerin, and there are even medications for atrial fibrillation called pill-in-the-pocket type of medications, which Dr. Oza can comment on, to break an episode of atrial fibrillation. There are no medications that we know that will cure a stroke if you should have one or having symptoms of it. Now, again, we do suggest taking an aspirin with chest pain and being on an aspirin if you have risk factors for cardiovascular disease. But unfortunately, there is no medication to just take if you have a symptom of a stroke, because we are not sure when you have a symptom of a stroke if you're having a bleeding stroke versus an occlusive stroke. So the last thing you would want to do is take a blood thinner out of the pocket if you're having symptoms of a stroke if we don't know what's actually causing it.
Okay. Does Medicare cover Watchman?
Medicare does cover Watchman, as most commercial insurances do as well. So that should not be an issue for the vast majority of patients who have come to me to get this therapy. So again, there are nuances with private insurance companies, obviously, but the main thing is if you have the legitimate background to get the device, obviously there should be no reason why an insurance company would not cover this procedure if you meet the criteria.
Thank you. Dr. Oza, when you were talking about lifestyle changes, a viewer noticed that you didn't mention caffeine. Is caffeine a risk factor for AFib?
So a lot of observational studies have been done about caffeine, and my advice based on those studies is 1 to 2 cups of coffee is fine with atrial fibrillation. Now, if you are that rare patient where you drink a cup of coffee and 2 hours later you are in AFib, please don't drink coffee. Coffee can cause atrial fibrillation if you are one of these people who, drinks 6, 8, 10 cups of coffee a day. Also, I do advise patients that caffeine in the form of coffee does have antioxidants and other substances which may actually have a slightly protective effect against AFib. That same protective effect is not present with sodas and energy drinks, so definitely stay away from those forms of caffeine.
And I'd just like to comment on that as well, that coffee and tea are usually hot, so the likelihood of someone just gulping it down is very rare. So you'll take your time in sipping coffee and tea. These energy drinks tend to be smaller and people tend to chug them and put them down very quick. That is another reason why I think these hyper-caffeinated quick drinks are more dangerous, because you can take more in quicker and get more caffeine in your system at a much higher rate, as opposed to drinking a very hot cup of coffee, which you would probably take at least 15, 20 minutes potentially to drink.
And I'd like to add to that also. The one patient I mentioned who was 18 years old and had AFib was a patient who used to drink about 6 to 8 of the little 5-hour energy drinks a day. And in the evening, he would mix them with alcohol. So the amount of substances this man was ingesting was phenomenal. And once he stopped doing those things, his AFib went away. This being Boulder in Colorado, I also have to say there are a lot of studies coming out that show, and ACC came out with a position paper recently on marijuana, where it does increase the risk of atrial fibrillation.
You talked about excessive exercise. Regarding weightlifting, would you recommend more reps with lower weight or higher weight with less reps?
So I do not have a recommendation. Weightlifting per se has not been shown to increase your risk of atrial fibrillation. The only time I have seen weightlifting cause AFib are people who hold their breaths and are not taught proper breathing techniques with weightlifting, because holding your breath can trigger an autonomic response that can put you in AFib. The data is for endurance exercise, so I'm talking about the long distance runners, the long distance bicyclists.
Okay, for paramyxal AFib patients, can they have other heart rhythm symptoms when not in AFib?
Can paroxysmal atrial fibrillation patients have other symptoms from other heart rhythms? Absolutely. A lot of patients with AFib will also have atrial flutter that we talked about. If a patient has both, we will address both of them during an ablation procedure. A lot of these patients will also have premature atrial or ventricular beats, which sometimes, if they are very frequent, can feel just like AFib. So we cannot tell in every patient as to what arrhythmia they are in just by talking to them. We need a recording on paper.
Is there a downside to long-term Pradaxa use?
Well, like we mentioned before about being on blood thinners, the longer you live and longer you're on blood thinners, the more likely a bleeding episode will occur. So that's just part of the HAS-blood score, and seeing the older you get, the more likely something will occur by being on a long-term blood thinner. So definitely having a blood thinner on board for a long period of time. Now, again, it doesn't go exponentially every day, every month, every week, but rather it's just something to be kept in mind that there is always an increasing risk as you get older to be on these medications. But again, that being said, I like to temper that with the score that you have, the risk of stroke versus the HAS-blood score, as well as your tolerance of being on the medication. If you are tolerating one of these medications, Xarelto, Pradaxa, Eliquis, with no issues, and again, I wouldn't look at it, well, 10 years from now, I might have a problem with this. I wouldn't look at it that way at all. I would say at the current time, if you are tolerating the medication, stay on it.
What is the risk of forgetting to take one of your 2-time doses of Eliquis in a day?
So if you forget to take one of your doses of medications, well, naturally, there is a heightened risk of having a clotting event happen. And that's because these medications, if they're twice a day, are 12-hour medications. We will tell patients very strictly, you have to be compliant with these medications. Trying to take 2 the next morning if you forgot last night's dose doesn't make any sense. That's taking an overdose of the medication and missing the dose the night before, which puts you in both negative areas. You want to be compliant with your medications. And again, if you have trouble remembering a second time dosed medication or BID dosed medication, talk to your physician about switching to one of the other medications that's once a day, because that might be easier for you. But there is no answer to saying, well, I missed 1 or 2 doses, is that okay? Well, unfortunately, with the medication only acting a certain amount of hours and staying in your body for a certain amount of time, if you miss a dose, there's a likelihood your body can form a clot in that time period.
Is there any correlation with AFib and altitude?
So the symptoms of AFib could be worse at altitude, but I like to say a lot of my patients ask me, should I move to sea level because now I have AFib? Well, if that was the case, nobody in Florida would have AFib, and I think Florida might have more AFib than Colorado because of the older population. So no, there is no clear cause and effect relationship. Symptoms might feel worse the higher you go.
Why are females more at risk for AFib?
You know, that has been debated as to why females are more at risk. We used to automatically assign a point for the female sex, we still do, but now we say that for the, let's say a 64-year-old female will have a CHA2DS2-VASc score of 1 if she has no other risk factors, and a man will have 0. Now we say that a male has to have a score of 2 and a female has to have a score of 3 before we anticoagulate them. So that additional risk with females is being debated right now.
How would one know if you were having leakage in your mitral valve?
I will let Dr. Iyengar answer that.
Well, it's a little bit off the discussion we talked about tonight, but because mitral valve disease is definitely something we can spend another hour discussing. But if someone has a leaky mitral valve, that could result in symptoms of shortness of breath, and that generally is one of the first things we notice. But also, sometimes people who have leaky mitral valves or something called mitral valve prolapse tend to have an increased incidence of palpitations, which may be presumed to be AFib. And again, just because your heartbeat is irregular does not mean you are in AFib. You need an EKG to document that. So if you have an irregular heart rate, it may be AFib, but it might just be palpitations or SVT or another type of arrhythmia, PVCs, which are all different types of ways of creating an irregular heart rate. So if you have a leaky mitral valve, symptoms usually related to shortness of breath with exertion can progress, if not diagnosed over time, to something called heart failure. But palpitations and potentially atrial fibrillation are all things that can occur downstream when you have a very leaky mitral valve.
Great, thank you. One viewer asked, I read a study that long-term use of Flonase can induce AFib. Have you heard anything about this?
I am not aware of that particular study.
Okay. Is it a good idea to contact your office if my CHAS-VAD score is 2?
Yes.
Okay.
And if you have not seen a physician, now realize that CHAS-VAD score of 2 applies to patients with AFib. So if you have AFib and a CHAS-VAD score of 2 and you have not seen a cardiologist, you definitely should.
Okay. Is there an alcohol threshold for increasing your risk?
The threshold for alcohol has gradually been coming down. So it used to be said 14 drinks per week for men, 7 for women. American Cancer Society, I'm sure a lot of you saw the news, do not drink alcohol. It increases your risk of cancers. Do not drink alcohol, it increases your risk of AFib. That's not a practical thing in this society because it's a social lubricant. We use it all the time. So my advice to patients is try to limit yourself to no more than 1 drink at a time, and don't drink every day. If you have AFib and you find that alcohol triggers AFib, I'm very clear. Would you let me burn or freeze in your heart so you can keep on drinking? Or would you stop drinking first? It's a very simple equation in my mind. So I would say aggressively modify lifestyle factors, limit yourself to 1 drink at a time. Now, obviously, there'll be occasions where you feel like drinking more. Realize it puts you at some risk. And it's not while you're drinking, it's always the next morning that you get AFib after drinking too much. And that's because the metabolites of alcohol, the formaldehyde, the same substance that is used to embalm bodies, forms in your blood. And that's what irritates the heart and causes AFib. Now, everybody's not the same. There are people who enjoy 1 or 2 drinks every day, they never have a problem with it. That's great. If you have AFib, I would say don't drink.
Is black tea okay?
Black tea is absolutely fine. Too much of anything is bad, though. Too much of black tea will cause AFib because black tea actually has not only caffeine but theophylline, both of which in high doses can cause AFib.
Okay. I think we'll make this our last question. So let's see. A viewer says, my GP, not my cardiologist, suggested I take daily magnesium to help convert. It's within normal limits. What are your thoughts on that?
There is some data on magnesium helping reduce frequency of atrial fibrillation. It does not hurt. Some patients may develop side effects like diarrhea with taking magnesium supplements. So I would say it doesn't hurt to try, but don't use it as your only treatment.
Is there anything else you guys would like to convey to our audience before we close up tonight?
I think we should let Vitaly talk about that.
I I would just say call us if you have questions. That's what we're here for. We have a team of excellent folks in our AFib clinic, and we want to be a resource for these questions. I'm sure we didn't get to all of them tonight, but that's why we developed this program. So call us, email us, and let me know how we can help.
Thank you.
Thank you.
All right, we've come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email tomorrow, so please fill that out. Thank you for joining us and have a wonderful evening.